realize that some people are still filing in. I can see the participant list continuing to climb, so we'd like to welcome you to the AO Trauma Hand online series, this being on soft tissue coverage of the hand and wrist, presented in the style of a journal club. This is the third of a series of 3 of these webinars. More of that in a minute. My name is Jeff Friedrich. I am at the University of Washington in Seattle, and I'll be serving as your moderator this evening, and I'm joined by 2 excellent faculty presenters, Dr. Paul Binhammer from the University of Toronto and Dr. Anthony Archul from Indiana University in Indianapolis. The requisite disclosure slide, none of the 3 of your presenters tonight have any relevant financial relationships. Just pause for a minute on the content validation statement from AO North America and let you look at that. So we are aiming to take a somewhat novel approach for this webinar to look at the principles of hand soft tissue reconstruction. I have an illustrative case that I think and we think has no single correct answer. And we are going to discuss a variety of reconstructive options for that defect and for other hand defects, all of which have distinct advantages and disadvantages. And we hope that this is going to be a learning opportunity for hand surgeons at every stage of their training and expertise, from the folks in training to even more seasoned practitioners. So that's our hope and our overview for this session. These are the learner objectives that we've developed. So we hope at the end of this series and specifically this presentation that you'll be able to understand reconstructive priorities for hand and soft tissue defects, to incorporate all of the pertinent factors, including the patient factors and patient desires that have to be synthesized into a reconstructive plan, and then describes a number of different hand soft tissue reconstructive options, and even be able to do a little bit of compare and contrast between those. This is going to be our agenda here. We're in the midst of the introduction and the presentation of the case, and then we'll go on to just generally grouped into radial forearm flap options, posterior interosseous artery flap options, non-flap options, including dermal templates, and then we'll kind of wrap it up with discussion from you and the other panelists, and some closing remarks. So hand soft tissue reconstruction is, I'm biased, but I think it's a great aspect of hand surgery. It's a lot of fun. It's very challenging. It challenges a lot of capabilities and techniques that we have. I think that there is definite science as well as art to it, and that is some of the, for me, the excitement of hand soft tissue reconstruction. Interestingly, most of our modern resources are 2-dimensional, but these are really 3-dimensional problems. They not only have the length and the width that you see on the page of the book or the page of the website, but they're 3-dimensional. They have a depth and they have a functionality and a dynamic aspect to them. And I sort of mused in the parenthetical statement there that they may be 4D because we really have to take into consideration the time, this notion of durability of a reconstruction over the lifespan of the patient. And so I somewhat a bit of grandeur there for me to state that it may be 4D, but I think that is a consideration that we need to have. Is this reconstruction going to hold up for what this patient wants to do for work, for recreational activities, for all of that? We as a specialty have a wide continuum of training and capabilities, even in the soft tissue reconstruction realm. We recognize that the hand surgery community, some people do some soft tissue reconstruction, and that ranges all the way to very complex free tissue transfer and other complex microsurgical endeavors that we can get into with soft tissue reconstruction. And so we humbly hope to increase your capabilities tonight, at least in terms of contrasting some of these different options. And so our focus tonight is going to be on all the different right answers, and that's also some of the beauty of soft tissue reconstruction is there's no single right answer. There's no, I guess there may be some wrong answers, but those are far less frequent than the number of right answers that we can conjure up for different reconstructions. You know, the general principles of hand soft tissue reconstruction, I'm for the most part stating the obvious here. We want to preserve length and preserve parts insofar as we can and still have it be functional. We want these soft tissue reconstructions to ultimately be durable over the lifespan of the patient. Sensibility is desirable, although some reconstructive techniques are better than others at restoring sensation to the area of soft tissue that is lost. We want it to be non-painful because ultimately we want this to be a functional digit or a functional hand, and if there is ongoing pain, then that's going to be substantially difficult. And I think, you know, all three of us panelists are plastic surgeons, and so you know, we will, I think all of us probably incorporate to some degree aesthetics into the reconstruction, and I think it's a valid concern. You know, we're not doing aesthetic surgery here, we're not doing cosmetic surgery, but the noticeability of the hand is a consideration for all of these patients because after the face, the hand is the most, second most noticeable part of someone when we meet people. So aesthetics is often not the primary concern of our soft tissue reconstruction options, but it is a valid concern as we're thinking through how best to get the patient back to a sense of wholeness and be able to get back to their activities. So this is a representative case that I wanted to show, and you know, every one of these is different, but the dorsal hand and wrist soft tissue injury and loss is kind of a classic, I think, and so that's why I wanted to focus on that. So this patient is a 35-year-old right-hand dominant man. He sustained or suffered a contact burn to his dorsal hand and wrist about 8 days ago, so just over a week. And our friends on our burn surgery service debrided the skin, debrided the full thickness burn down to extensor tendons, and there is extensor peritoneum lost and maybe a little bit of extensor retinaculum, although difficult to tell. And then they applied allograft skin, which, as you can see there, has a variable adherence. There's some peripheral areas that are quote unquote taking or sticking, but you know, certainly that central area with extensor tendon and maybe exposed CMC joint is not looking as good. So what would be the priorities for this patient? And I'm asking this somewhat rhetorically, but you know, at a minimum, we would hope to get a durably closed wound. We want to get tendons that move and glide, specifically those extensor tendons, and more specifically the digit extensor tendons. I would say less so the wrist extensors, but all are important. We would hope to help this patient return to work in the least amount of time possible, and then to have, for lack of a better term, a non-noticeable hand. We don't want a reconstruction that is so bulky or so otherwise noticeable that it's going to distract people that he meets or that he encounters in his work. So we have a series of articles that I think you've all been sent and have access to that we are going to go through. We may not get through all of them, but hopefully we can get to the salient points of each one. I'm not going to read out each of these because we're going to go through them a little bit individually. I'm going to a second and a third page here. These are our discussions about hand-based flaps for dorsal hand and wrist soft tissue reconstruction. And then finally, we will work on this notion of dermal templates because I think that's a very common method of reconstruction, particularly in community practice settings. So it bears looking at that. So I've droned on quite a bit, and I would like to now turn it over to my partners here, and we'll start with this article in the radial artery perforator flap.
Thanks,
Jeff.
Jeff. That was awesome. Great introduction. Archie, I think you might have chosen this article.
Yeah, when I heard about this webinar, this is the first article that popped into my mind. And what you'll notice structurally as we go through these articles is we'll leave these questions to the left. We won't necessarily touch on every single point for all of them, but this is kind of how we'll frame the discussion. And the reason this article I think popped into my head is because it's something I didn't learn about in training, but a flap that I was taught by my boss, Jen Walge. And this article is a technique paper from the Journal of Hand Surgery from 2010 about this radial artery perforator flap. It's a very concise technique paper. It gives very clear indications for when to use this flap with a color-coded diagram of areas that you can typically reliably reach or cover. It gives a good review of the anatomy and some pearls and pitfalls, and then one illustrative case. The bottom line or the basis of this flap is retrograde blood flow from a group of perforators that originate 2 to 4 centimeters proximal to the radial styloid along the course of the radial artery. They are very reliably present. You don't need to do an Allen's test on a patient before doing this because you're basically just harvesting the fat and fascia from the volar forearm based on those perforators. So the radial artery doesn't have to be sacrificed. You can cover a wound in a single stage. And although this paper's, I think, does a really nice, concise overview of the technique, there's not really any data here. So it's just a single case and description of their technique. One thing that I've run into that I would ask the other panelists to comment on is typically when I do a fascial flap, I have taken to doing some kind of non-autograft skin over the fascial flap, and then at a second stage doing a skin graft, because I found that the skin graft take on a fascial or adipofascial flap is a little bit shaky. And I'm wondering if other people have the same preference or maybe pearls surrounding that. And then another thing that is almost a joke in our residency is that I don't like to tunnel a flap. And I'm curious with a flap that's this thin and pliable, whether that would be an indication to tunnel it, especially in the case that Dr. Friedrich showed where it's got to go to the dorsal hand.
Paul, what's your experience with the adipofascial flaps and maybe that skin graft take, or my experience with it has been a little bit of marginal necrosis, so a little bit of crustiness around the edges. What's your experience?
I would say I have the same experience about skin grafts, but I've never staged one. I've always done one, and it's just taken, rather than look perfect when you take the dressing off, it looks almost perfect and seems to get through it. I certainly like this illustration. If you ever have a problem with coverage over a median nerve or recurrent carpal tunnel syndrome, I've found this flap useful in that situation. And tunneling, I think tunneling is a complex topic. I think it depends upon whether, like, if you're doing this for soft tissue coverage for somebody who's got, I don't know, a tumor or something, where they have no swelling, there's no associated trauma, then I think I can usually get away with tunneling more easier than if I have a trauma case and I start to think about tunneling. Then I start to think twice when I'm doing a trauma case because I'm worried about swelling, and so I might change over and open up the skin and design my flap differently. Jeff?
And Dr. Archul, I have the same aversion to tunneling that you do. I think. What do you do instead? Do you just make a trench and skin graft over the entirety of the flap? How do you do that?
Yeah, it depends a little on the situation. Oftentimes, what I'll try to do is an opening in such a way that I can let the skin slide a little and then reclose it. So I guess it's still a tunnel, but I can control exactly how loose I want it. But if, in the instance where I can't do that, like I do a lot of limb salvage, I'll just connect the incision right to wherever the flap's coming from and skin graft over whatever I need to.
Mm-hmm. Do either of you, Dr. Benhammer or Archel, do you try to see the perforator or the cluster of perforators, or do you just have a distance, say, from the radial styloid that you just say, we're going to dissect to here and stop? What's your view on viewing the perforators?
I think in this particular flap, some of and maybe one of the other papers we're going to discuss, but there can be up to like 10 very small perforators in this area. So it's not as if it's one dominant one like you might see in some other flaps. So in this instance, I'll just stop at 4 centimeters or get more cautious at 4 centimeters proximal to the radial styloid, and then just try to preserve that area. I always point these perforators out or examples of them when I do distal radius because there's always those crossing vessels at the distal FCR. I feel like those are the same perforators we're talking about here.
Yeah. Dr. Benhammer, your take on how much to skeletonize or view the perforators?
I think it depends upon the flap that I'm elevating. I think I always see the perforators. Whether I skeletonize it, I think that's is flap dependent, depends upon how big your perforator is. And I think it also depends a little bit on your, I don't know, you could either say comfort level or stupidity level.
Yeah.
So if you do some, if, I don't know, if as part of your practice you do limb salvage and you work around some lower extremity perforators, then maybe you become a little less averse to risk at looking at perforators.
Okay.
Sometimes they're pretty small, but you want to be careful. Like it's sort of the undercurrent here is that you don't want to burn yourself.
Yeah. that comfort versus stupidity continuum, sometimes that's a very fine line in the middle. At least in my experience. Great. One more question. What do either of you have I guess for lack of a better term, a surface area at which you think, this is going to be too much for a perforator flap, and I need to convert to a more traditional axial flap, whether it's a radial foreign flap or something else. Do you have that in mind, that kind of upper limit of a perforator size?
I don't have a hard and fast rule for this particular flap. I have pushed it once or twice and been pleased. So I think probably my pendulum is prepared to swing back the other way if I have a bad outcome. But for now, like I've resurfaced a large area of the palm with this. Probably like 10 by 10 centimeters.
Okay.
I think your earlier discussion about 3D, 4D was very pertinent to this question.
Yeah.
I think if, like Anthony just used the example of a palm defect, if your defect is close to that distal, whatever you want to use, 2 centimeter radial, 2 centimeters from the radial styloid point of rotation, then you can take. So if your arc of rotation, and I think we have a picture coming up later on, if your arc of rotation is small, or your flap is close to your pivot point, then you can take a larger flap. But as you move away from that, like as in this sort of illustration at the top, that flap's not very big at the distal far away. So I would be hesitant to use a a big radial artery perforator flap which is long away. I think when when you're long away, then you got to change and take the radial artery.
Yeah. So it's pivot point distance. Yeah. Okay. I do want to keep an eye on the clock. Oh, dang. Sorry about that. And go on to the next one. This somewhat similar article from Drs. Page and Chang. So, any thoughts on this one?
So this is a great article because it talks to you about the flaps, tells you its advantages and disadvantages, gives you some heads up about challenges. I think this is the article that talks about, retrograde issues, like with the inclusion of a vein and how you have to make decisions about including or not including the vein. So this is really a good article about the radial artery flap, perforator flap, the posterior interosseous flap, and the Becker or dorsal ulnar flap.
Yeah. I don't know why I keep switching off of presentation mode, and I apologize for that. That was a little distracting. This is from that article about, it's kind of a comparison of those in terms of first and second choices for these different defects. And you can see, at least for this patient that we're talking about, we can look here on the left side, the dorsal kind of column, and see all these different options that we have. So
I think your case is interesting because it's really neither radial nor ulnar.
Yeah. And
I probably wouldn't call it extensive either. So I think that means you kind of have the world is your oyster. You could probably choose any of these things depending on your experience and what you think the patient would do well with. But I like this chart from this article. I think this is a helpful guide for maybe people that don't do this a lot or that don't have experience with all of these. This reassurance that you're on the right track.
Yeah, I like that the world is your oyster. Oftentimes, at least for me, it's for something like that, case that I've been showing, it's we'll ask the resident of the fellow, well, what do you feel like seeing? Now that's a little bit facetious because we do need to keep in mind the patient's needs and wants and their input into it too. But as I said at the outset, there's not a single right answer for a lot of this stuff. This one is, again, staying in the theme on the perforated radial artery flap, comparing it to the quote-unquote classic fasciocutaneous axial flap. One of you want to kind of dissect this one a little bit?
I think the first two papers did not have a ton of data in them. It was more cases and thought process. And I think this one, although it's a really limited sample size, at least presents a direct comparison. So it's a head-to-head comparison of the radial artery perforator flap and a more traditional radial forearm flap. And there's 10 patients in each group. For some reason, they call them Group A and Group B instead of just radial forearm flap and perforator flap. But that's what they're comparing. A is the classic flap and the perforators in Group B. And so this is a gap in the literature. There's really not studies comparing these two. They did very pragmatic outcome measures, mostly the patient's satisfaction with the appearance and the appearance based on a scoring system. But really, patients in both groups did well. They did cite cardiovascular comorbidities as a risk factor for complications, especially with the perforator flap, which makes sense because you're basing this on, pretty small perforating vessels. So it's obviously not an enormous sample size, just 10 patients in each group, but it still gives us a good head-to-head comparison and some guidance as to how to choose maybe one versus the other.
Right.
I think people will often cite that as a problem really with either of these flaps is the appearance, because your donor site from a traditional radioforum flap is going to be potentially unsightly, but it's a pretty long scar either way, and a skin graft over a fascial flap is not always aesthetically pleasing. So it might depend on the area or the patient's concern or what they do with their hands.
Mm-hmm.
Just speaking to that issue of if you'd like cosmesis, sometimes it's good to, although it's a traumatic case and you're trying, or maybe a traumatic case, it's good to look at how much subcutaneous tissue is in the forearm versus the hand, because that can really may push you to saying that I'm going to raise this flap as all things being equal, as a fasciocutaneous flap and not as a fascial flap and not a fasciocutaneous flap, because I'm going to end up with a hamburger on the back of the hand just because of how much subcutaneous tissue there is in the forearm compared to the hand in some patients.
Yeah.
And I think that's one reason I think it's interesting to include this article, is because they spend so much time addressing the cosmesis of the flap, and I do think it as we've sort of said, it bears consideration when you're making a choice.
A couple of questions about that. Well, one statement is that I found that even in the most slender patient with the most slender forearm, I'll look at the radial forearm and go, oh, this is going to be great because they're very thin. And it's still thicker than dorsal hand subcutaneous tissue, no matter how skinny the patient is. And often not tremendously so, but usually noticeably so. And so I think that with any of our forearm flaps, that's probably something to bear in mind is in nearly all the population, the subcutaneous fat in the forearm is still going to be thicker than that on the hand. Has that been your experience, Dr. Benhammer, Dr. Archwell?
Yeah, actually, I have a patient that had a pedicled radioforum, fasciocutaneous flap, traditional flap, and came to our practice just because she found it so unsightly, and we liposuctioned it till the cows came home, and she still didn't really like it, and she was very thin, and got it really functionally a great result, but just was really frustrated with the sort of pincushioned appearance of it.
Yeah. And I realized that she came to you afterwards, but when using the retrospectoscope, what could something have been done differently? Is that somebody that would have been better served with an adipofascial flap with a skin graft? What did you think about after that?
Yeah, it did give me some pause, because I do think it would have been a more aesthetically acceptable result to her if she had a fascial flap with maybe a sheet graft. And I think if I was encountered with a similar wound to her, especially in somebody with a really low BMI like she had, I would probably, I think that encounter would affect my decision making.
Yeah. And another thing that this brings to mind is how we assess the aesthetic, not to totally go down the aesthetics rabbit hole, but I think it bears a little bit of analysis. How do we assess it with our patients? Is it a binary, hey, you like the way this looks or you don't? Or is there a more nuanced way to do that? And then academically, how do we assess it? There's not many instruments that I know of other than the Vancouver Scar Scale to get an objective assessment of scar appearance. So, thoughts on that from either of you about how we get that information from our patients and how we get it in research?
I think from our patients, you got to ask the hard questions. Um, just ask them about their concerns and stuff, and listen to them,
Yeah.
as painful as it may be. When you've thought you've done a great job,
Yeah.
because it's an eye opener, right? Which is fine, right? It's
Yeah.
good. There is something called the SCAR Q, which I haven't used, but it is a scientific measure to look at patients' perceptions of their scars. That's called the SCAR Q. I didn't see it in any of the papers
Yeah.
that we were looking at.
Yeah, and this SATI-VAS, it's like visual analyze analog score of the patient's overall satisfaction
Satisfaction. Yeah.
with the appearance. It's not an instrument that I'm familiar with, but that is what they were, hoping to assess with that. And as you can see, it trended toward better with the perforators, but really wasn't statistically significant, barely a difference.
But
Yeah.
yeah, I think it's likely going to trend towards the perforator because it's going to be likely a smaller defect or
Yeah. It's a good point. Is there some built-in, not bias, but as we talked about in the prior paper, or two papers prior, it's generally we're doing those perforator flaps for smaller defects. So, yeah, fascinating. I'd be interested to know from any participants tonight if anybody has any experience with the SCAR Q or any of these other instruments. Please contribute in the Q&A your experience with any of them, because it certainly seems to be a bit of a gap in our collective knowledge about how best to objectively assess. So, all right. Well, don't want to totally go down the cosmetic rabbit hole, but as we said before, it bears analysis. So, in keeping on this topic about the radial artery perforators, this is, I think, an article that a lot of us have, appreciated and referenced in no small part because the illustrations are super cool. But I think, Dr. Benhammer, did you want to talk on this one a little bit?
Sure. I chose this or selected this exactly why, Jeff, because you said the illustrations are super cool. I think they're really great for anybody trying to understand or appreciate what's going on here. I think it's also good. They did 26 forms that were dissected, so it's a fair number. And besides the latex studies, they did, I think it's 5 India ink injections as well to understand what that, especially what that distal perforators in terms of the skin is supplying. So it's not really, I think there's a case in there, but to me, this is more like this is an anatomical study that I think is valuable whenever we're planning our flaps. Is if you can go find a study that's looked at the vessels that helps you understand what you're going to do better than just the clinical outcomes, exactly what you're trying to do from a technical perspective. And I think that's one of these types of articles.
Yeah. Dr. Archel, has this article changed anything for you in terms of how you think about perforator flaps, or has it made a good roadmap for you? What's your take on it?
Yeah, I think well, first of all, I'm glad it's not just me that felt like I need to up my game when I publish something with figures. But
Yeah, no more pen and ink
yes,
drawings.
no colored pencils. But I think there I like this study because it really I find it reassuring, really just how rich the vascularity can be in these two zones, and it's nice to know that how reliable these areas of perforators are as long as you can respect a big enough area of them.
Yeah. Yeah, this one for me, combining that with some of this other, particularly the Page and Chang article, really gave me the courage to start down the road of perforator flaps, in the forum because knowing that there's no single perforator to the radial forearm flap, and knowing where there's a pretty rich network made me feel a little more courageous, let's say, to do the first one. So I really appreciate these type of studies. Cool. Again, I want to be mindful of time and give people plenty of time for discussion. And please, if you do have questions, comments, tomatoes to throw, please do so in the Q&A. And I'm happy to monitor that and ask those concurrently as we go through these different options, these different articles. The last several papers that we have discussed have focused on the radial artery system. We've talked about the quote unquote classic radial forearm flap. And then in some ways, these perforator flaps have been designed to ameliorate those concerns or mitigate those concerns about loss of one of the two major arteries to the hand, the radial artery. And there's, I think, varying concerns, and they vary regionally, depending on maybe how cold a place is, about people's concerns about things like cold intolerance and things like that. So that is kind of our group of radial artery system flaps. And so I want to go now to the next kind of smaller series about the posterior interosseous artery system and its suitability for this dorsal hand wounds. So maybe if I could go back to Dr. Archwell and have you give us the scoop on this one.
I think every time you talk about, especially dorsal hand wounds, the PIA flap's going to come up, and this paper is really nicely done. It's 68 cases. At the time it was published in 2007, it was the largest case series of these flaps. They go through the history of the PIA flap and the anatomy of it. Authors do a retrospective review of 68 patients. They ranged in age from 4 years to 68. The mean was in the late 30s. The preponderance of patients was male. It was 56 to 12, male to female. They were almost all fasciocutaneous flaps, although they did have 2 osseo-fasciocutaneous flaps in the mix. They talk about their flap dimensions, and they graded the outcome as good, satisfactory, or poor. They do a really extensive review of the anatomy of the posterior interosseous artery and its perforators. I do like their operative technique description. They talk about using the tourniquet without exsanguinating, the access of incision they make, and how they try to preserve the flaps, perforators. And I have to say that this is a flap that every time it comes up, a lot of people groan or people talk about the bad experiences they've had with it. But I think this paper gives a very honest take on how to get it to work well. Authors do encourage to take at least 2, if not more, perforators from the posterior interosseous artery into the flap skin paddle, which I could see being a pitfall that a lot of people fall into. It is a large case series that gives a lot of detail as to their technique. They have 10 years of follow-up. Interestingly, I forgot to mention that the cases were done at 2 institutions, one in New Mexico and one in Pakistan. But they talk about the learning curve and the early failures people tend to have with it. And really overall, it gave me a slightly more positive opinion of this flap, and I think we would be remiss if we didn't talk about it in this discussion. So I'm glad that we were able to bring this paper as part of it. Um, my questions would be, I guess number one, does either of you or does anybody do this flap? And if so, what do you do if you find that there's not that critical anastomosis with the
Hmm.
anterior interosseous artery?
Dr. Benhammer, what's your take on the PIA flap? Is it in your repertoire, so to speak?
Yeah, I like this flap just as much as any other flap. I haven't had to abandon one yet. So yeah, so far so good. They do in their description, which I thought was really good. I always tell the residents or whoever I'm operating with is find the ECU first because it's like the landmark. They said 5 millimeter fascia. I take more fascia than that for this
Yeah.
flap, 5 millimeters. I think I'm like close to 2 centimeters, like
Yeah.
on the ECU tendon, on the EDM tendon. So I'm
Yeah.
gathering more fascia maybe than they do. Um, in particular, um, I love this flap for tight web spaces.
Hmm.
And the reason why, it just seems that like when you turn the flap, it's like lining up in the right direction
Mm.
and you can fold it over and so that you can, if you have a web space where you're creating a web space where there was none and you got to really fold the flap on top of itself to fill that web space with fat, you can do it with this flap. So,
Yeah.
um, I'd say there's one other technical thing they mentioned about reach in this. And one thing you can do, and this is published somewhere else, it's not my idea, is you can, and this sort of goes to also about tunneling, but you can also exteriorize the pedicle on this flap, which can help you reach it further if you're in a tight spot. Um, so you don't tunnel the pedicle, you don't cover it with a skin graft. You can just leave it exteriorized. And you can then divide it, at 2 to 3 weeks, and then just divide
Oh.
it. So, yeah, that's my thoughts.
I
And I
know,
thought this was a great article, very honest.
yeah. And that exteriorization, when are you needing that? Do you need it, like when you're trying to really get Palmer in a first web space? When does that come up?
I'd say it probably comes up when I'm really trying to get the flap a little bit further than I normally do, or if I'm in maybe a trauma case, and I think everything just looking too swelling, and I'm just gonna put 2 layers of Gelinet or Vaseline impregnated gauze over top of it, over top of the pedicle, and then just dress everything else.
Yeah. And that notion about taking all the perforators that you can, it's classically described as the quote unquote main perforator is almost at the midpoint between the lateral epicondyle and the ulnar head in terms of distance. What about more proximal perforators? Are you needing those? Are you taking those? And how do you go about that?
So what I do is open up approach it from the posterior or the ECU muscle, so that then I can open up the interval all the way up as far as I need to. I can look at the motor branch going into the ECU if I need to. Yeah, so I don't mind opening up that interval. And there's an article by, I think it was Buchler who wrote this article about, and he's got a couple of diagrams in there. This is like, I think it's early 90s. called it the most relevant proximal perforator that he
Mm.
would take.
Yeah, I like this flap a lot. I use it quite a bit, particularly for the first web space, particularly for our firework injuries that have a big gaping first web space. Um, I have been reluctant to take those more proximal perforators, in part because they also seem to be somewhat entangled with the motor branches to the ECU muscle, the nerve branches, and I've been reluctant to want to disentangle that. And the Page and Chang article talks about that phenomenon, and that it often is not necessary to take that more proximal perforator, but but more is usually better for flap perfusion too. So it can be a balance. Okay. Yeah, it's a great. The other thing that I have my now sort of hackneyed sayings that I say to the residents, and one is that I tell people the radial forearm flap is the go anywhere, do anything flap from the hand. You can put it to the fingertips and the thumb tip and the palm and anywhere, and the PIA is not that. The PIA can reach to roughly the metacarpal phalangeal joints, so the non-thumb digits. It can reach to the first web space and out mostly onto the thumb, but it just doesn't have quite the reach or the surface area that radial forearm flap does. Dr. Binnehammer or Dr. Archwell, do you have any kind of constraints like that about to what degree you'll push a PIA flap?
I mean, I pretty much agree with you. I think that may be another reason for its negative reputation, is just that it can't be the dorsal radial forearm flap.
Yeah.
It only can do what it can do.
Yeah.
Agreed.
Yeah. Well, the time is flying. I'm sorry about that. I do think it is important to discuss. I think we'd all agree not everything needs a flap, and there are some. We talked about indications being pushed for these different types of flaps. I think there are people that rightly push indications for non-flap coverage, even for things with exposed tendons. So maybe I'll turn it over to my panelists to talk about this one, about dermal template for hand soft tissue reconstruction.
So this article is using Integra, but there's other dermal templates, just to be fair to other companies out there, like Matroderm and Novasorb and Alloderm, et cetera, et cetera. But this is, I believe, 14 patients, I think, were in this study. The defects, I think, were around 35 square centimeters. They talk about in the paper functional outcomes. It's a little bit hard to understand their functional outcomes, but they had 97%, I think, take of it, and high satisfaction, whatever that means. It did take about, because these all were put on the template, then skin grafted later, that it was about roughly a month until they got skin grafted, as I recall. I think it was something like the range was 21 to 32 days. They immobilized some, didn't immobilize others. They also talked about that they did some DIP arthrodesis and then would put a piece of Integra over that. They also had some extensor tendons exposed. It wasn't clear exactly how much. But anyways, they reported good outcomes. But I think, I don't know, but other people's experience, I think for sure Integra has dermal matrices have a role to play. Um, they don't always give a, sometimes they're a little bit frustrating.
Mm. Yeah. Dr. Archul, what's your experience? Do these have a role in your practice in hand soft tissue reconstruction, and if so, how?
Yeah, they do for me. I wouldn't say I use them as often as the residents suggest it. It seems to be the ripcord for when they're not sure what else we should do. But that's because I think they've seen them be successful. So
Yeah.
I will tend to use them. In one instance is when I'm gun shy about using the patient's own skin, and I just want them to prove to me that they can incorporate something, granulate something well.
Feel it.
That's one time, and like the fascial flap example from the beginning that I mentioned, and then I will also sometimes do it in the immediate trauma setting where there's a large area of, let's say, exposed fat or something like that I'm not comfortable grafting right up front because I feel I may still need to debride more.
Yeah.
But I'll use it in that situation as well.
Yeah. This kind of gets into a little bit of, that the classic reconstructive ladder or reconstructive elevator. The classic teaching is use the simplest method that will allow wound closure, and some of these wounds are amenable to closure with a dermal template. But I guess my question would be, who's it simple for? Is it simple for us or simple for the patient? So, what are your thoughts about how do you balance a two-stage dermal template where a couple of short surgeries, one to put on the template, one to put on the skin graft, versus a longer single surgery with a flap? Do you have a way to balance that in your mind?
Yeah, I don't. We only got 3 minutes, and that's a complicated like algorithm. But I think one thing that's interesting about this paper in particular is that they seem to be pointing out that you can use this over exposed tendon, bone, or joint. And I wouldn't say that I do that all that much. And I think in those situations, then I'm definitely going to be looking at something more complex.
Yeah. Dr. Benhammer, any final thoughts on that? And then we'll kind of throw it open to questions from the group.
Well, I think that's good.
Yeah.
I'm going to ask Archie one question.
Yeah.
So have you used this on fascial flaps, adipose fascial flaps, and do you think the cosmetic result is better?
I have, and I don't know if I do. I don't know if it's the cosmetic result, but I think the skin grafts take beautifully because by the time I do it, it's like a perfectly pristine granulated bed. Yeah.
Great. Well, we were perhaps ambitious in terms of the number of articles that we were attempting to get through tonight, and I'm sorry about the projection thing. This is a little bit weird.
I think you shepherded us through them so well that there's not even a single question.
I don't know about that, but so I do want to give time for discussion. We do have a couple of other papers on intrinsic hand flaps to close or cover dorsal hand and wrist that I just don't think we'll have time to get to. Well, I don't know why that is. That flipping back and forth for you guys when I'm.
Yes.
Yeah, I'm sorry about that. I don't have a good reason about why it's doing that, but I'll try to stop it. So in terms of our discussion, happy to have any. I still don't see anything in the Q&A, so maybe we've put everything to rest tonight. So, or just baffled everyone. Anybody from the audience? Any other of our faculty members that are here that want to give us your thoughts? Are we off track on any of these things?
Jeff, what did you do for the patient at the case example?
So great question. I think I hinted before, I'm a huge devotee of the PIA flap, and this one was a little bit close. As you can see, it's somewhat close to the the distal radial ulnar joint. Although it was a thermal injury rather than a crush or an avulsion, and so I felt a little bit okay about that. Although it was not, I was several dozen PIAs into my experience, and so probably felt a little bit more comfortable about that. The question came up before about have you bailed on any PIAs if you don't find that anastomotic connection with the anterior interosseous artery? I have once. I've made an incision distally and bailed out just because I did not see that connection. But it's nearly always there, and I've done 45, 50 of these. The other reason I like the PIA, you can do it as a fasciocutaneous. You can just do it as an adipofascial. I can get a few more of them closed primarily, even if it's a fasciocutaneous, when compared to the radial forearm flap. I can't get any radial forearm flaps closed primarily, even with undermining, but the PIA I occasionally can. But it's not perfect. It's, when I put it down onto dorsal hand, or particularly in the first web space in hairy men, it can look like a caterpillar in the first web space. So that's its disadvantage. It's radial forearm flap, generally much less hirsute than our PIA flaps. So it's got its limitations, but that's what I did for this one.
Excellent.
Got one in the Q&A. With patients, somebody asked, with patients who don't follow up, how often do you find that dermal replacements like Integra are actually taking well and providing a really good bed with skin coverage? Really good question. I mean, and maybe I would kind of rephrase that as, what do you do about the dermal template that's got pus under it? Whether it's Integra or BTM, how do you manage that?
Yeah, I have had some either that are just very small areas or where the patient disappears reepithelialized, and that's always like a pleasant surprise. But when they get infected, I do usually, I'm pretty aggressive with washing it thoroughly and debriding, and trying pivoting to something perfused.
Yeah, I would.
Same.
Go ahead.
I was just going to say agree.
Yeah.
Same.
Just to respond to Dr. Keplinger, is in my experience, it's spotty. They can come back if they haven't followed up in a while, and some parts of it look great, and other parts you're like, and so we'll unroof that part of the silastic and try to drain out stuff. But it's a decent amount of maintenance in the time before you got to skin graft them. Another attendee said, for radioform donor sites, do you ever purse string to decrease the site, and how does this affect the cosmetic appearance in your experience? I've done that with, I would say, limited benefit. The circumferential purse string, Dr. Spinhammer or Archwell, what's your experience with that? Oops.
I don't usually purse string, but I'll use a mattress suture with like nylon or Prolene that goes from one side to the other. This may get a little weird. So if you have a big defect, and I do this everywhere, but if you have a defect, you can take mattress sutures on opposite sides to get your hole smaller, and use like tie over bolsters. Put the skin graft right over your sutures that are sitting on top of your muscle. And so I'll do that, which is,
okay,
I guess, sort of the same thing as a purse string suture.
Yeah, I'm just reducing the surface area. Yeah.
And I find that works well, and you can pull those sutures out pretty quick, like 7-10 days, and wound stays closed.
Yeah, great idea. Well, those are the only two questions in the chat, and we have run over time, so I apologize for cutting into people's evening time. Just a couple of other things to announce, and if you got a phone, you can scan the QR code for these things. The online series continues with the third series, which is the arthritic thumb, and you can see the dates there in May, June, and July. And the My weird slide thing continues. Upcoming in-person courses, and again, you can scan the QR code for these. The hand and wrist course in San Diego in just about 2.5 weeks, and that is a cadaver course. The hand and wrist fracture management course is that's a fundamentals course in Ann Arbor. That's a sawbones course, and that's a 1 day. There is a recording for this, and it will be sent out via link in about 24 hours after the conclusion. And so you'll be able to watch it all again if you choose to do so. And then finally, you can live stream or see AO Trauma Hand events and more on orthotvonline.com. So I want to thank my amazing panelists, Dr. Benhammer and Archwell. I want to thank AO North America for organizing what, non-biased, but I think this is a great journal club. And I want to thank all the participants there for giving us your time on a Thursday evening. So thank you so much.